All right, so next is the motor system. Okay? And we write normal bulk and tone, 5 out of 5 strength throughout, no involuntary movements. Okay? Normal bulk and tone, 5 out of 5 strength throughout, no involuntary movements. And I'll explain what that means, in the next couple slides. All right. So again, this is the pathway that we're primarily talking about. Cortical spinal tract goes down, be lesioned anywhere along this route, makes its synapse in the spinal cord, and then the alpha motor neurons talk to muscle. And remember that there is a homunculus on the cortex. You know all this, okay? And so, you can get parts of the body more involved or less involved depending upon what part of the homunculus is involved. And again, here's the pathway you need to know in every slice of brainstem and spinal cord where the cortical spinal tract is and where it crosses and all that good stuff. You should already know this by now, all right? So atrophy. Now, if you look at somebody and they have one bicep that's this big and the other bicep is this big, okay, don't get excited and think, oh, this person has lower motor neuron disease, they're going to die, okay? When you see, again, asymmetry implies pathology but doesn't guarantee pathology, so you talk to your patient. Have you noticed that your one bicep is really big and the other one is... Well, I just got the cast off in this arm. I just broke my arm and I just got the cast off. So again, so you can get atrophy from disuse, all right? If you don't use it, you lose it. So that's one reason for atrophy. But when you see it symmetric like this, here's the person's thenar eminence, this little fleshy part below your thumb. It should be nice and fleshy and it should be sticking out. Well, this guy, look, it's almost dimpled in. And when you look at the back of his hands, you can see all of his tendons, and he's very weak in his hands. That's atrophy. And atrophy implies lower motor neuron, and that is always bad. Okay, lower motor neuron disease can kill you. We talked a little bit about electromyography in a previous lecture. And what does this EMG tell you? Okay, so they stuck a recording electrode in the muscle, and you see these things. So does that tell you that the upper motor neurons are sick, dying, or irritated? Does it tell you that the lower motor neurons are sick, dying, or irritated? That there are signs of denervation here. Lower motor neurons are sick and dying, and there are signs of denervation. Okay? So when you have lower motor neurons that are sick and dying, you're going to have some problems with weakness and with fasciculations, and when you have denervation, you're going to see fibrillations. So this is an EMG that you may see with somebody who has Lou Gehrig's disease. You've had the lecture already on Lou Gehrig's disease. That person with the small thenar eminences, that was a person with Lou Gehrig's disease. Okay? And again, you've seen this again. What normally happens is when there's denervation is that some of the neurons that are still alive will pick up some of the muscle cells, but not all of them. And that's why you see these fibrillations here. And again, here's our picture of the person who has Lou Gehrig's. And you can see the tongue. If this was a video, it would look like there's worms underneath his tongue because all of the fasciculations that you would see. All right, so next is muscle tone. And muscle tone could be normal, decreased, increased, or I don't know. I have no idea. One thing about the neuro exam is that you can't skip any parts, all right? So if a person, you can't visualize the discs, let's say, you can't just skip it. Because again, we imply that if you skipped it, or you didn't write it down, you didn't do it, all right? If you have to skip it for whatever reason, you need to write down why you're skipping that part. So if the person is not cooperating with the exam, you say discs are not visualized due to patient uncooperation. Okay, so that's what you do. But when you have a person who's not participating with you, let's say he's an old man who can't hear, what? You're saying relax, and you're trying to move his arm around, and you don't know what the heck you're feeling. There's a name for that. It's called paratonia, okay? Or Gegenhalten in the German. So when you're assessing somebody's tone and you don't know what it is, you have actually a medical term for that. It's called paratonia. Okay? Most of the examination, again, requires a patient that's going to cooperate with you. So let's have a patient. I need a volunteer. Hurry, hurry, someone. Come on. Okay. So I talk to the patient and I say to the patient, I'm just going to move your arm around. Just relax, okay? And there should be some elasticity of a person's normal muscle, okay? If a person, let's say, had a spinal cord injury and he's paralyzed and his gamma and his alpha motor neurons are not working, I would pick up this weak arm and it would be like picking up, an inanimate object, okay? And that's called flaccid paralysis, all right? More so seen in the lower motor neuron diseases that you see with babies that usually kill them. They were born with lower motor neuron diseases, like picking up a bag of flour that's half filled. The limbs are just, they're called floppy babies because they're literally floppy when you try and pick them up. So we don't see too much flaccid paralysis in an adult, but we see more increased tone. And you can't say that a person just has increased tone because there's two types, all right? So there's spastic tone and rigid tone. How do you tell them apart? You tell them apart by if they're velocity dependent or not. What do I mean by that? Okay, so here's my patient, all right? Let's say he had an old stroke on this side, but he's strong again on this side. But let's say he has some spasticity in this arm. And I would notice that by if I moved his limb slowly, it would seem pretty normal, okay? But then if I increased the velocity, whoop, I'd get some resistance, and then it would melt, like opening a pocket knife. Clip, it's called the clasp knife reflex even. So it's velocity dependent. However, in the Parkinson patient, where they have rigidity, which is another type of increased tone, but it's in the basal ganglia, rather than the upper motor neuron, which is spasticity is upper motor neuron. Here, it wouldn't matter how fast or slow I'm going. It would be like bending a lead pipe. Okay, lead pipe rigidity, it's called. Okay, so it wouldn't matter how fast or slow I'm going. I'm getting resistance every which way. Thank you. Now, what do these numbers mean? Okay, so that's the next thing we need to go over. So, 5 is normal in this grading system, and 0, of course, is nothing. All right? A 1 is a flicker of movement. 2 is movement but not against gravity. 3 is movement against gravity but not full range of motion. 4 is breakable weakness, and 5 is normal. And when we say 5 out of 5 strength throughout, we actually mean that at the minimum you have to examine these muscles. And they are. And many times what I do is I write them out. If they're not 5 out of 5 throughout, I write them out in a column and row form like this. I put right over left, okay? And then I do, these are the muscles you got to examine. Deltoid, bicep, triceps, wrist flexors, wrist extensors, hand intrinsics, iliopsoas, quadricep, hams, atib, and gastroc. Those are the minimum. When you say that you've examined somebody and they're 5 out of 5 throughout, you have to say that you examined all of those muscles. Okay? Now, let's say sometimes I write them out like this because I'm looking for a pattern. Okay, does anybody see a pattern there? Somebody said it. Proximal muscles, that's exactly right. You notice this? These are all proximal muscles. And over here, these are all proximal muscles. And that actually has a name. This pattern of weakness is called the myopathic pattern of weakness. Okay? And it implies, usually, that the person either has a problem with the muscle itself or with the neuromuscular junction. So this is the pattern of weakness that you're going to see with myasthenia gravis. Okay? Now, let's say it was just the opposite, where the distal muscles are weak as compared to the proximal muscles. That's called the neuropathic pattern, and usually seen with people who have peripheral neuropathy, where the tips of the nerves get damaged first, and so as a result, they're more distally, they have a problem. So, let's say I'm the patient, all right, and I'm asked to extend my wrist, all right? So here's my hand, and I'm going to extend my wrist. That's a 0. Instead, let's say I do this. That's a 1. Okay? Now, let's say I do this. Now, that's more than a flicker, but I haven't moved it up against gravity yet. So that's a 2. All right? So the minute I lift it up off the table against gravity, that's a 3. And this is all 3 until I get to full range of motion. And once you get to full range of motion, if you can break the person, that's a 4. If you can't break them, that's a 5 or normal. So that's what those numbers mean. Okay? So I want to see you back here again. Okay, first put your hands up like this. Don't touch your hands. All right? And keep your arms up. Don't let me push you down. What am I testing? The deltoid, which is this triangular muscle that does this when it contracts, right? Okay? Right, relax. Pull. All right, what am I testing? The bicep. Okay, push. Okay, what am I testing? No. Okay. He's pushing with the side of his hand like, I need you to push with the back of your hand only. Now that's tricep. Okay? So don't let the person turn their hand on you. They have to push with the back of their hand in order for it to be tricep. All right, stop in the name of love. Okay. Lock your wrist there. Don't let me pull them down. Those are wrist extensors. Down. Okay. Lock them. Don't let me pull them up. That's wrist flexors. Okay. Now relax. Are you right-handed or left-handed? You're right-handed. Okay. Now stick your fingers out. All right. Make your fingers like iron. Really strong. All right. He's weak. Call a doctor. Call a neurologist. Oh, I'm a neurologist. Is this fair? How am I doing it?
No, you're cheating.
I am cheating. Okay. I'm using two fingers against his one finger. I'm using my dominant hand against his non-dominant hand. Okay. So the way to be fair is that, first of all, you need to know what's the dominant hemisphere in him. So you have to ask him, what? Are you right-handed or left-handed? That's the first question should be out of your mouth even before you touch the patient. Okay? And so push thumb to thumb. Ooh, he's strong. Maybe I'm weak. Another way to do a quickie hand intrinsic exam is do the OK sign like this. Push real hard, okay, and don't let me pull my finger through. Okay, so even a little old lady can do that. Okay, so that's a quickie to do the OK sign. All right, so put your hands aside. The iliopsoas. What muscle is that? What does that do? Well, it actually starts inside your belly, and it comes down to your proximal leg. And when it contracts, what does it do? It flexes your hip. So am I going to say to the patient, flex your hip? He's going to say, huh? So instead I say, go like this. So go like that. Hold it there. All right? And that's testing the iliopsoas. All right, relax. Stick your leg straight out. Lock your knee. What am I testing? Quadricep. Okay, relax. Now I'm gonna try and straighten your leg out. Don't let me. You ready? Here we go. So what am I testing? Hamstrings. Okay, relax. Bend your foot up. Okay, what am I testing? Anterior tibialis. Again, think about where the muscle is, and when it contracts, what is it doing to the joint below it? So you picture this muscle doing this, so it's going to make your foot go like that. Dorsiflex, okay? And then step down on the gas pedal. That's the gastroc and soleus that is making his foot go down. All right? Thank you very much. Give him a hand again. Again, so those are the muscles that you must test. Now, some people with myasthenia gravis have a weak neck, so you can actually push them like this and they'll go, whoa, or push them from behind and they won't, and they'll start to do this. Okay, most persons, can't do that, of course, and this is how you would do it. So you may want to do that additional one with a person who you suspect may have myasthenia gravis. But these are the muscles that you all have to test, and you're going to test them like this on your patient next week. And again, here's this is in your slide set, so that if you want to go over exactly how to do these, and I just showed you how to do it, that's for your review. Okay? And this is cheating, 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 cheating. All right? Oh, one other thing. is that sometimes a person, you check the individual muscles, and they're not really weak, but you still suspect that they may have some subtle weakness. So there's another test to do, and it's called the drift test, okay? And this is a picture of it. You have the person stick their hands out, and if one of the arms drifts down and pronates, then this is a sign of subtle weakness in that arm. Next, you must document any involuntary movements you see and describe them the best you can. So first is tremor, like in Parkinson's disease, which should have some rhythm to it. Next is chorea. The patient, he's dancing around, and of course Huntington's chorea can also do that. You all had a lecture, right, on Huntington's chorea, all right? And sometimes the chorea is associated with a writhing. So that's choreoathetosis, if it's athetosis, all right? Tics, again, is the little jerks. Myoclonus, when a big muscle jumps, okay, that's a myoclonic jerk, all right? Ballism, again, subthalamic nucleus. So you see the flinging movements. And then, of course, little fasciculations when there's lower motor neuron irritation. That could be another involuntary movement that you may see. Let's go on to part number 4, which is the sensory. And we write normal pinprick, vibration, and proprioception. Okay? So, pinprick, vibration, and proprioception. Those are the 3 things that we're going to test. Now, why do we test those 3? Because, again, it's always linked to anatomy. So, remember the spinothalamic tract? What is the spinothalamic tract modalities? Pain and temperature. Remember the dorsal column medial lemniscus pathway? What are they those modalities? Vibration and proprioception. What about the 4 spinocerebellar tracts? They also proprioception. So, when we stick somebody with a pin, we are testing the spinothalamic tract, the integrity of the spinothalamic tract. When we hit somebody with a tuning fork, or have put a tuning fork on their body, we are testing the dorsal column medial lemniscus pathway. And when we're testing proprioception, we are testing, either the spinocerebellar pathways or dorsal column, depending upon whether vibration is also involved or not. So remember that you have a pathway, again, that starts in the dorsal root ganglion, and we're measuring here a sensations that would either be proprioceptive-like, okay, they're going in the dorsal column medial lemniscus pathway, or a pain sensation that would go cross in the midline immediately and go into the spinothalamic tract, and they should be followed. You should be able to follow those 2 pathways all the way up to the cortex. All right, so this is how you test proprioception. You grab the digit. Let's actually, I need a volunteer. Volunteer. You're sitting up front. Come on. Have a seat right here. Okay, so the trick to proprioception is that you have to grab the digit from the sides. If you grab it from top and bottom, you're giving them pressure cues. So you don't do that. And you want to test 1 digit in each limb. So when you get to the toes, you got to grab in between those toes and not grab the toe like this. And you're going to wiggle it. Okay? So I'm going to tell the patient, I'm going to wiggle your finger and your toes. This is up. This is down. You just tell me up or down. Okay, close your eyes. Wiggle, 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 wiggle. Where are we? Up. Okay? So if she gets 1 right, we go to the next one. She gets that right. Go to the next one, get that right. Go to the next one, that right. Okay? And then we go on. If she gets it wrong, we're trying to find a pattern. Okay? So is it just with this finger? Or is it just with the dermatome? Or is it with the nerve that's going to the muscles that move this finger? Or is it, how far does it go up? Is it, so if she got this wrong, then we would next do this, and then we'd next do this, and then we'd next do this, next do this, to see how far it goes up. Because that's another pattern called the stocking glove pattern, which is a neuropathic pattern. Just like the muscle weakness, distal more than proximal, was a peripheral neuropathy problem. A sensory problem also can be stocking, like a person has stocking and gloves on. Okay? So again, we're looking for patterns. Tuning forks. Got all kinds of tuning forks. Let me show you. All right, here's one. It's very high frequency, 512. And this is the one we use the Weber and Rene test on. Okay, so we don't use that one. Then there's a lower one, 128, and then there's one in between, 256. So the one that you want to use, or that's used most by neurologists for this part, is the 128, the real big one. The reason for this is that you can strike it without the patient knowing, and that's the whole idea. So this is what you do. Show the person this is a tuning fork, not going to hurt you, all right? I'm going to put it on your scalp. You feel that? That vibration? Okay, I'm going to touch your fingers and toes with this tuning fork. Sometimes it's going to be buzzing like that sensation that you felt, and sometimes it's not, and I'm going to try and fool you. You ready? Okay, close your eyes. Are you ready? You don't want to do that, because I think she knows it's vibrating, all right? So, you ready? Okay. Vibrating or not?
Not.
Are you sure? How about over here?
Yes.
Okay, did you hear me hit the tuning fork? That's the whole idea, okay? So when you're using the tuning fork, don't let the patient hear that you've hit the tuning fork, okay? Otherwise, it kind of defeats the purpose, right? And again, we look for a pattern. So if she can't feel it here, we go up here, we go up here, we compare this to this. You know, we're looking for what is the pattern of her deficit. Is it a dermatome? Is it a nerve? What is it? All right, and again, we're primarily looking at this dorsal column medial meniscus pathway, which I've shown you 100 times before. Now, pinprick. This is the pinprick exam. It is not the broken tongue blade exam or the broken Q-tip exam. It is the pinprick exam. And so you have to use a pin. Usually we use a safety pin, and you have to reassure the patient because they may get scared. You come flying at them with this thing. Say, look, this is a safety pin. I'm not going to hurt you. Okay. Now, I skipped something. What did I skip? On the cranial nerve exam, I skipped something. I didn't test the sensation of her face, did I? Okay, and I'm going to do it now because it makes more sense to do it now. You do it all together. So I'm going to say, I'm going to take this pin, and I'm going to poke you, okay, on your face, and in your hands, and in your feet, and you're going to say sharp or dull. Okay? So let me show you what that sensation feels like. So you pick a part of the body where this is pretty normal. This is normal right here, would you say? Okay. So this is the sharp side. Okay. You don't have to poke them really hard. That was pretty sharp, right? Okay. And this is dull. I don't have to make the person bleed or anything. That's dull. And you could tell the difference, right? Okay. All right. So I'm going to start with your face. So you got to tell them that, because they may be expecting that you're going to start with their arm, and you start poking them in the face, and they're not ready for that. Okay. So we're going to start with your face. Close your eyes. Okay. Tell me, is this sharp or dull?
Dull.
Okay. How many more times do I have to poke her in the face? Minimum. 2, 1, 5, 5. All right. How many dermatomes are there in the face? We just learned that. How many? 3 on each side. So 6. So is 5 right? Why is it 5 right? Because I didn't even start yet. I did this, which is dull. You see dull up there anywhere? Dull tells you nothing. Dull is just used to keep the person honest. So I haven't even started yet. I have to poke her with the pin, okay? In 6 dermatomes. Boop, 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 boop. Then I'm done, okay? And then, of course, you do it with the you do it with the finger, and her eyes would be closed. And again, you're looking for some sort of pattern, all right? Thank you. Give her a hand. So again, you have to explain what you're going to do, and you show them with their eyes open, that they're not scared, that they're going to be poked with a pin, and then you warn them you're going to start with the face. Then you look for a pattern. Okay, if there is a deficit, you're looking for a pattern. So you need to know these dermatomal patterns. Okay. What is the pinky? What level is that? What is the thumb? What level is that? All right. So you need to know these dermatomes. On the trunk, it's kind of tricky because some of the dermatomes that are cervical actually go into your arm, And so as a result, T2 abuts C4, okay? Because many of the C's, the rest of the C's, and up to 8, and T1 is going to go into your arm, okay? And when you poke somebody at the umbilicus, that's actually T10. Actually, you would think it's probably lumbar, but you know, it's not. It's T10 at the umbilicus. The nipple line is T4. So these are things that, I mean, you need to know what these levels are on the trunk, all right? And as well, you need to know where they are in the limbs, all right? So, like, for example, S1 is the sole of your foot and lateral foot. The rest of your foot is L4, 5. In your hand, you're 6, okay? 7, 8. So the middle finger is 7. These two are 8. And your thumb and index finger is 6. Okay? So I remember that 6. I'm making a 6 here. All right? So 6, 7, 8 in your hand. And so you see the T and C5, you know, they're higher up on your arm. And so you need to know these dermatomes, because they're related to roots. And many times what happens, that's where the problem is. As the root is coming off the spinal cord, that's where the injury is. There's a bone spur, or there's a disc that's popped out and it's hitting one of those roots, and you lose sensation, or you have decreased sensation in one of the root. Or you have painful sensation. If it's irritated, you'll actually get a shooting pain into that root. All right? And so these are the patterns here. Again, C6, 7, and 8, like this, which are the most common ones that go into your hand. The axillary nerve, again, it could be nerves as well. So when you get a nerve, you usually have sensation as well as motor out, okay? And as a result, you know, you can have this bullseye for the axillary nerve, and they won't be able to work their deltoid, so they'll be weak in their deltoid. And that should tell you, that combination tells you, oh, it's the axillary nerve, okay? So knowing anatomy, critical, all right? So the wrist drop, and you see this is the sensory area is gone here. What nerve? That's your radial nerve that does that. Okay, so when you see that, that's a radial nerve lesion. This is the claw hand, or the bishop's hand. He's blessing you. Bless you, my son. Okay, so this is the sensation gone here. This is the ulnar nerve. If you see the distal more than proximal with sensation, again, this is the stocking glove pattern. Very common in dieback neuropathies, where the distal part of the nerve is affected first. Most common with a very common disease. What's the disease? Diabetes. Diabetes. Okay? Diabetes is a bad disease. And again, depending upon where the lesion is, it can give you different patterns. You can even have a band of anesthesia on your trunk. That's, again, related to the center of your spinal cord being lesioned.